Hello and welcome to the next installment of our webinar series, Non-invasive Prenatal Testing, Background, Science, and Clinical Implementation. My name is Patty Tunasia, and I'm one of the genetic counselors here at Illumina. It is my pleasure to introduce today's speaker, who will provide an overview of her own effective implementation of non-invasive prenatal testing, or NIPT, into her busy practice. Dr. Tina Ziania is an obstetrician gynecologist in San Diego, California, who has been in practice for more than 17 years. She's affiliated with Sharp Memorial Hospital and Sharp Mary Birch Hospital for Women and Newborns, the largest freestanding women's hospital in the western United States, with over 9,000 deliveries in 2016. Dr. Ziania has been a member of the OBGYN department of the Sharp Reese Steely Medical Group since 2006. She's been offering NIPT testing to patients since 2013. Dr. Ziania, thank you for being here.
Thank you very much, Patty, for that lovely introduction. I work at Sharp Mary Birch Hospital for Women and Newborns. This hospital opened up in 1992 to serve the San Diego community. Now we're doing over 9,000 deliveries, as Patty mentioned. I've been working with Sharp Reese Steely since 2006, and it's a multi-specialty group, 500 provider group with almost every specialty. And there are 20 board-certified obstetrician gynecologists in this group. And we do about 3,800 of these 9,000 deliveries per year. Here are my disclaimers and disclosures. What I'd like to point out today is opinions expressed in this webinar are my opinions and may not represent the opinions of Illumina. Also, the main focus of our talk is non-invasive prenatal testing, and this is a screening test, not diagnostic. As Patty mentioned, this webinar is one in a series that covers various topics related to NIPT, where previous lectures have focused on the science behind the test, general clinical management guidelines, and discordant case studies. I would like to take the time today to walk through how I have personally implemented non-invasive prenatal testing in my own practice. What do we do in our very busy obstetric practice? At the initial OB visit, all pregnant women should be offered prenatal assessment for aneuploidy by screening or diagnostic testing options, regardless of maternal age or other risk factors. This ideally should be at the first obstetric visit. Also, the practitioner should go over the difference between screening and diagnostic testing. In our practice, most patients typically call in when they have a positive pregnancy test. Some patients are late to prenatal care, but the majority of women have a positive pregnancy test and call our office right away. These patients are offered a group prenatal visit. In this group visit, all newly pregnant patients can come in, hear a review of what they expect in prenatal care, and get a PowerPoint presentation that includes prenatal screening and testing options. They gather literature, they get handouts, and see videos. This presentation is given by one of our nurse practitioners. This is a great opportunity to review serum screening, ultrasound, and diagnostic testing options available at various gestational ages. To have patients see this presentation and review options gives them an opportunity to consider and possibly choose which test they want to do before their initial visit with the physician. At the first visit with a physician or nurse practitioner, a transvaginal ultrasound is done to document fetal viability and dating. When you see the patient, you want to make sure you have accurate dating in order to go ahead with the appropriate screening test, and you want to make sure you have a viable fetus. You don't want to spend 15 to 20 minutes going over prenatal screening options when you may have a non-viable pregnancy. So we always do the ultrasound first. Then we review what the patient recalls from the OB group visit and review the aneuploidy screening options. Most patients have pretty much made up their minds or have a few questions regarding some of the testing, and we'll go over it at this first appointment together. This is one of the slides that we show in our PowerPoint presentation during the group visit. Patients get a handout of this, and it shows all the tests listed, including the diagnostic test versus the screening test, and during which gestational ages each option is available. Our nurses are the ones that really sit with the patients and help them understand when to go to the lab for the test they've chosen. The nursing staff writes the gestational weeks and the dates the patient should go to the lab on the patient lab slips, which is very helpful. What we want patients to understand is that with all screening tests, there is absolutely no risk to the fetus. These are blood draws, or maybe a combination with ultrasound and a blood draw. A negative result on any of these screening tests does not guarantee a baby without a birth defect. There are many other causes of birth defects, and there is no screening for many other birth defects. How many times do you have a patient come in for screening and they think that they're 100% guaranteed a perfect baby? That is not true, and you want to reiterate what we are testing for so there's no confusion. What we do after the discussion in pretest counseling, we show the patient a prenatal testing consent form. We've listed every genetic testing option, invasive versus screening. The patients will initial whether they accept or decline the test, and then they will put their signature at the bottom and date it. This is a good way to confirm the patient understood the testing options and which test they choose to proceed with. So let's go into counseling consideration. So how do we counsel patients? How long does this take? Everyone is worried about how much time this is going to take. With our OB group visit, that cuts down a lot of the time we have to repeat ourselves to each individual patient. So let's go into pretest counseling considerations. You want to give your patients informed choice. You don't want to be directive of what tests to choose. What the patient chooses is ultimately up to her. You're going to do the typical things you do in an obstetric visit. You're going to get history to determine optimal test offerings. You're going to obtain a maternal medical history, a pregnancy history, family history, carrier test results. You're going to discuss the benefits and limitations of the screening test versus the diagnostic test. You want to review performance, false positives, false negatives, and what this means. And what are you going to do if you have an abnormal test? In my experience, all this information I have to go over for a traditional screening test already took a lot of time. If they don't go to the group visit, it takes about 10 to 20 minutes. Adding NIPT to the list of options may add only about 1 or 2 additional minutes. So what are the limitations of NIPT? I think this is a wonderful test, but obviously every screening test has its limitations. We want to make sure that people understand risk assessment is limited to specific common fetal chromosomal aneuploidies. This is not testing for all fetal anomalies. NIPT is testing for specific aneuploidies, trisomy 21, trisomy 18, trisomy 13, and sex aneuploidies. You want to make sure your patient understands this. No assay is 100% specific or 100% sensitive. And when you have a negative result, this does not eliminate the possibility of one of these conditions being present. This is called a false negative. If you have a positive screen result, it could be a true fetal finding, or it could also be confined placental mosaicism, fetal mosaicism, or a false positive. Rarely, results may represent chromosomal changes from the mother. For example, maternal malignancy, mosaicism, or transplant. So there are some limitations. The good news is that NIPT has superior false negatives and false positive rates as compared to any of the other serum screening methods. What are you going to tell the patient after post-test counseling? Once again, you want to hit home that only specific aneuploidies are screened for with NIPT. There are false positives and false negatives. They are very rare, especially as compared to other serum screening methods. And you, as the clinician, want to look at the complete clinical picture. For example, if your NIPT is negative, but you see multiple abnormalities on an ultrasound, the patient may still need invasive testing, microarray, and further testing. You want to look at the whole clinical picture, as always, as we do in obstetrics. Post-test counseling, what do we do after an abnormal result? Always remember, with an abnormal result on NIPT, you want to refer the patient to have a detailed anatomy ultrasound and genetic counseling. We refer them to a perinatologist and offer amniocentesis or CVS if they are early in gestation. Other counseling and management considerations depend on various clinical and medical issues, including the patient's history, gestational age, and ultrasound. Some patients decline invasive testing, so obtaining a detailed ultrasound and seeing a perinatologist is reassuring enough for them. Just to summarize, we have a test here that has a lower false positive rate, a much higher detection rate than what we're offering in standard screening today. Remember, our patients come first, and the patients have so much anxiety when they get a false positive for aneuploidy screening on a quad screen or serum integrated screening that NIPT is a better test. I really hope more practitioners will start implementing NIPT and offering it to all patients, because it is far better than what we're offering in standard screening. Thank you.
Thank you very much for joining us today.